It's a real pleasure to welcome Professor Lynda Powell from Rush University, Chicago. She's one of the most famous researcher in behavioral science. She has two qualities: a famous researcher, but also a woman that likes France, maybe wine also, French wine. Elle parle français, mais elle ne va pas oser, alors que moi j'ose parler anglais, alors que bref, elle parle mieux que moi. Ouais, vous voyez ce que je veux dire?
Speaking English,
so it's a real great honor to welcome you. You know that behavioral and non-pharmacological intervention, it's a universal problematic, and we have to change all the aspects of the research to be more efficient to the practice. So welcome, Lynda. It's a real honor and pleasure to be here. Thanks.
Merci beaucoup. Désolé, c'est tout le français.
Thank you very much. That's about the French. I can speak.
I'm very happy to present to you what we're doing in the ELM multi-site trial. And I want to start by saying we're trying to fix 4 problems. The first problem is that the metabolic syndrome, which is having at least 3 out of 5 cardiometabolic risk factors, is increasing and it's spreading. So when we started ELM, we used to talk about the metabolic syndrome as affecting 1/4 of the American population. When we started recruiting, we talked about it as saying it's affecting 1/3 of the American population. And currently, the most recent statistics are that it's now affecting 43% of the population. I tried to figure out what the problem is in France, and I could not find any recent statistics. This one is from, is from 2006, 2007, so you were at 21%. We're still higher than you. I'd love to know what you are right now. But basically, it's a problem for us, serious problem for us. It is not a disparities problem. Usually when we have problems that are exacerbated in certain underserved groups. That's not the problem. It occurs equally in men, women, Black, white, and Hispanic Americans. And the reason I say it's spreading is because usually there are groups that are not affected by some of the chronic disease problems that we worry about. One of them is young adults. So you could say, well, wait a minute, the population is aging, so of course we're going to, because age is such a big risk factor for the metabolic syndrome, of course we're going to see with an aging population an increase in the metabolic syndrome, but it's increasing in young adults. In 1988, it was 10% of young adults, and now it's 25%. It's increasing in college graduates. It's increasing in Asian Americans, which before were never really affected by this. So it's not only increasing, but it's also spreading. Problem number 2, we're not treating the fundamental cause. So here's the metabolic syndrome. It starts with people developing central adiposity, carrying fat around the waist. And then once that starts setting in, then we have elevations in the cardiometabolic risk factors, blood pressure, triglycerides, glucose, and a depletion of HDL cholesterol. When you have 3 out of 5 of these risk factors, then you end up at great risk for diabetes, heart failure, cardiovascular disease, and some cancers. When we started ELM, I thought, okay, this is an important risk factor for chronic illness. But what we found during the COVID pandemic, that one of the big risk factors for infection and also mortality from COVID was the metabolic syndrome. So what's the problem? The problem is that it starts over here with lifestyle. So you have an energy imbalance. You're eating too much poor quality of food relative to a sedentary lifestyle. And in addition to that, the experience of chronic stress is an independent risk factor for the metabolic syndrome. And so what are we doing with these factors? We're not doing anything. We're just waiting until people have the metabolic syndrome and treating them with drugs. So that's problem number 2. Problem number 3, I call it the check mark. Okay, so what's the check mark? For those people who are taking seriously the idea that we have to do something about lifestyle, what do we do with our lifestyle interventions? Well, we do interventions, but they have the same effect, which is the check mark. So the check mark, whoops. From the Diabetes Prevention Program, this is the check mark. This is the lifestyle program. This is the drug intervention. This is the placebo. So what we have here is the outcome here is change in weight. We have a big change in weight at the end of the first year. And so if we stop our intervention at the end of the first year, we say, hey, this is a wonderful intervention, it works. But if you then start following people over a longer period of time, we have them come gradually back to where they were at the beginning. That's the check mark. And we're getting lots of questions right now from health economists who are saying, why is this important? If we just have a short-term effect, why is that important? Because ultimately it's not going to save healthcare costs if people just keep coming back to the way they were before. So this problem is the problem of the check mark. Problem number 4, what we're realizing is that the strategies that we use to change behavior are focused on initiation of behavior, how you start people on a new health trajectory, but that there are a different set of strategies for sustained behavior. And so what do we have here? We have, we have the current status quo. These are strategies to initiate behavior. It's coming from the frontal cortex, executive function, and you may have heard of some of these strategies. We call them self-management strategies, and they are things like self-monitoring, problem solving, goal setting, and relapse prevention. They're all coming from the frontal cortex. So what's the problem here? The problem is that over time, people get tired exerting the effort that's required to use strategies from the frontal cortex. In addition to that, in the presence of stress, people revert back to old habits. They let go of the new habits that they're trying to develop in the frontal cortex. And so our problem here is that we have short-term action, i.e. the check mark. So Einstein said insanity is doing the same thing over and over and over again and expecting a different result. So that's kind of where we are with this. You know, if we just keep using these frontal cortex executive function strategies, we're just going to keep coming back to the same result, which is the old check mark. So what's the fix to that? Well, the fix to that, and you know, we are learning so much from the field of basic neuroscience, and what we've learned is that when people engage in ongoing, entrenched habits, it's not mediated by the frontal cortex. The frontal cortex doesn't have very much to do with it. It moves to the back of the brain, to the dorsal striatum. The dorsal striatum is the center for automatic habits. And so the question then becomes, why not just initiate behavior using the strategies that we know so well, but in addition to that, add some strategies that are uniquely targeted to sustaining behavior. And these strategies are going to come from the dorsal striatum, and they're going to require repetition until the habit becomes automatic. So if we combine this with this, we may get sustained action, and we may have a benefit on this check mark. So that's the spirit behind the ELM trial that we want to get at. ELM trial is a sustainability trial. And what we want to try to do is get a remission of the metabolic syndrome that's sustained for at least 2 years. Now, in preparing for this talk, I was fascinated to read some of the literature that's coming from NPI. And one of the things that I was happy to realize is that the NPI model is a mind-body model. It's not only focusing on the body and what you eat, but also the psychosocial sides. And that's what ELM is as well. It's a mind-body interaction. So we have a synergy here. Then we turn to the literature on how you develop automatic habits. So an automatic habit means I do it without thinking about it. It's just a part of my daily routine. So how do we get people with a metabolic syndrome who have firmly entrenched old habits of sedentary lifestyle and low quality diets to engage in these new habits? And that's when we get to the literature on habit formation. And there are 3 different things we have to do. Number 1, we have to simplify the targets of the intervention, because the principle is that the simpler the habit, the easier it is to become automatic. So we have translated diet, physical activity, and emotions into 4 habits that we're trying to have an impact on. One is, we call it the perfect plate, preferring a half plate of vegetables at meals. The second is enjoying a brisk walk on most days. And the last 2 are mindfulness. So mindfulness is a very complex set of practices. But what we have done with each one of these habits is we've gone back to the literature and said which behavior is most highly associated with metabolic abnormalities. And when we got to mindfulness, what the literature is telling us is that emotion regulation and sensory awareness are the 2 components of mindfulness that are most highly related to cardiometabolic abnormalities. So now what we have is we have 4 simple habits that we're trying to have an impact on. The second thing we know about automatic habits is they're triggered by cues, not by outcomes. Frontal cortex strategies focus on outcomes. You're doing something because you want a particular outcome. In automatic habits, the focus is on the cue. There are repeating environmental cues that cue the habit. So how do we make that happen in our intervention? So our intervention is the process by which we intervene is we bring people in, we go for a walk together, we prepare a vegetable together, and then we sit down and we eat and we converse. So that is an ecologically valid set of daily experiences that people go through that give us the opportunity to invite people to explore new habits. So that's the second piece. And then the third piece is repetition. In order to get a new habit to become automatic, you have to do it over and over and over and over again. And so what we found is that if we tell people to do that, we've got them in groups, they come to small groups once a week, and then we've got all that other time in their daily environment where we're trying to get them to engage in these new habits. And what we found is that for us telling them to do it, it kind of goes in one ear and out the other ear. But if they tell each other to do it, it's much more powerful. So everybody gets a Fitbit, and we have a function in Fitbit that enables people to talk to one another during the course of the day. And this is an example. This participant took a picture of the sunrise and sent it around to her group members and said, "This is a lovely morning, autumn is in the air." So what they're doing is they're communicating and encouraging one another to keep going in the times that we don't have the group. The overall trial that I'm describing to you today has a long history of treatment development. And so for this, I went back to the NPI model as well, and what we follow is the orbit model. And so I was trying to find the connection between the orbit model and the NPI model, and it happens here in the intervention study, and it happens possibly in the prototype study. I'm not sure I really understand it well enough to know. But basically, the orbit model is talking about early treatment development. It's a progressive model, but it's not prescriptive. And what we're trying to tell people to do is find where you are in the orbit model, because once you understand where you are, the kinds of questions you ask and the methods that you use to answer them become easier. And what we're trying to do is avoid people trying to answer all questions in what we call one fell swoop, one big study where all questions are answered. And usually those studies don't work out very well because there are too many questions and too many competing demands. So anyway, Orbit was developed with, ELM was developed with the Orbit in mind. So one piece of Orbit is design. So back in 2005, I brought together a group of people, medical and behavioral science, researchers and clinicians, and I said, I am tired of promoting change that is not sustained over time. What can we do to sustain change? So for the better part of a year, we talked about it, and we came up with an intervention. And there are two things that I think rose to the top about what was important in this qualitative study. And one was target emotions. You know, at the time, everybody was focusing on diet and physical activity, and this group said, no, target emotions because they play an important part in this, and nobody's really worrying about them. And the other thing that I thought was really important is they said, you know, our patients don't worry about developing a heart attack at some later point in time or developing diabetes. They want to feel better right now, so focus on immediate consequences as opposed to distal reinforcers. So those are the kinds of, you know, we learned a whole lot more from this group than I'm telling you right now, but those are the things that rose to the top, and it made it possible for us to pull together a package, an intervention package. And so the second question we said, well, you know, we don't know if this is going to work at sustained remission of the metabolic syndrome or not. Let's just try it out in a proof of concept study. So we did a proof of concept with 26 people. It was quasi-experimental, treatment only. Our goal was 50%. We were trying to get 50% remission of the metabolic syndrome at the end of 2.5 years. Why did we choose a goal of 50%? Because that's what we have for adherence to drugs. 50% of the people who are prescribed drugs adhere and 50% don't. And so over the course of the follow-up, what we found is that we actually achieved, so this is the intensive phase of the treatment, and we actually achieved remission of the metabolic syndrome without much treatment at the end of 2.5 years. So that got us, okay, now we've got this huge intervention. Can we optimize it? Can we pare it down? So we went through what we call an ELM, the refine phase, and I pulled together a group of people that I called the ELM experimental group. And these people all had the metabolic syndrome, and we said, we don't know what's going to work, but we want to try some stuff out on you. So we want you to be guinea pigs for us. Are you willing to do that? And lo and behold, some people said, yes, we're more than happy to do that. So during the course of 6 months with this group, we tried out different things, and they taught us a lot. One of the things they taught us is that mindfulness is a really important part of this, because when you watch people eat who have the metabolic syndrome, the most important thing that you notice is they eat fast. You know, food has become an enemy. So they eat as fast as they can, and then, you know, it's something that is now behind them. But the mindfulness approach has people slow down and appreciate the moment as they're eating. So mindfulness, we decided to emphasize mindfulness much more in this population than we had before. And then the other thing that was pretty cool about what we did is everybody had a Fitbit, but there's a function in Fitbit, it's called Fitbit Friends. And as long as you give each other your cell phone number, everybody gets the number of steps you're taking in a particular day. So what this gave us the opportunity to do, and we didn't do this. This came from the participants themselves. But there's also a function here that's cheer or taunt. Celebrate success or say, you know, you're not doing what you should be doing. And it's this kind of thing that the participants really capitalized on. If we had said to them, if we as the professional had said, you know, you should do more, it just goes in one ear and out the other. But coming from the participants themselves, it was particularly powerful. So now we have a refined and optimized intervention, and now we're ready to work toward the multi-site trial. And the way we work toward that is we ask the question, we know we can do the intervention in Chicago, but can they do it at a distal site? So we did a feasibility pilot study at the University of Colorado, and guess what? They did better than we did. They got more weight loss than we did. So we were encouraged by that because we thought, oh boy, you know, not only can we do it, but others can do it, and they can do it better than we can do it. So that led us to the trial that I'm going to describe to you now, which is our multi-site trial. It's a 6.5-year trial. We're halfway through the 6th year. It's got 5 sites. So Colorado is in the west. Kansas City, Missouri is in the south. Chicago is a diverse urban environment. Rochester, New York is a suburban northeast environment. And the Geisinger site in eastern Pennsylvania is a very rural site. In order to do the intervention, people had to drive sometimes 2 hours to get the intervention. The aims of the trial, as I said before, are sustainability. Our primary aim is to see if we can produce a remission of the metabolic syndrome for as long as 2 years. Unfortunately, we're still analyzing the data, so I can't talk about the sustainability outcome, but I can present to you what we look like at 6 months. So 6 months is the end of the intensive period before we start the maintenance phase. Part of what I'm going to be talking about as we go through this is the principles, the methodologic principles we follow in doing multi-site trials. And one of these principles is development of a hypothesized pathway that will guide the interpretation of results. So this is our hypothesized pathway. As we were developing the intervention, it started off being a really big hypothesized pathway. In each study we did, we were able to pull it in and make it more precise. So here are 3 components. Here are 4 habits. We have implementation targets. That is, can they do a brisk, are they actually doing a brisk walk for 30 minutes a day on most days? That's implementation. We have a mediator, which is the behavior automatic? So we use the self-reported habit index to get at the issue of, is it automatic? When we say, is it automatic? Just think of it from the point of view of saying, I do it without thinking about it. And then we have over here the actual behavioral risk factor targets. So these are all targets that are measured with standard behavioral measures, all of which have been related to the metabolic syndrome. So if we can get automatic habits, and if we can get a change in the behavioral risk factors, then the hypothesis is we should have a reduction in the metabolic syndrome. And so this is basically a piece of methodology that we haven't talked very much about, but we published a book up here, and there's a whole chapter based on the hypothesized pathway. Why is there a whole chapter? It's because we want to interpret results of our behavioral trials accurately. So we could have, when all is said and done, we could have a positive trial. We had a benefit on the metabolic syndrome. So then the second question is, why? Is it because we were able to target the whole process and therefore we had a benefit? Or it's possible that none of these things changed, but we had a benefit on remission of the metabolic syndrome. So that would, the interpretation of that would be, we had a positive trial, but we have no idea how we got the positive trial. By the same token, we could have a null trial. And if we have a null trial, the question is, how did we get a null trial? Is it a failure of the hypothesis that these things will connect to remission of the metabolic syndrome? Or is it a failure of our intervention? Most of the trials, 80% of the behavioral trials we do end up as null trials. And almost all of them are because we couldn't do the intervention as designed. So having a hypothesized pathway helps us interpret what the results are. Was it a failure of the treatment or a failure of the hypothesis? This is the design of the trial. It's sort of simple-minded. We randomize people to 2 arms. We do an intensive phase over 6 months, and then we do 18 months of follow-up with minimal check-ins over the course of the maintenance phase. Now, there are some things that are important about this. One is that the comparator has a neutral name, self-directed. The treatment has a neutral name, group-based program. We do not use comparator and treatment as we're talking with anybody, our participants or anybody in the trial. It's always self-directed versus group-based. Everybody in all of the arms gets a Fitbit, and everybody in both arms get education. The only thing that's different is that this group gets the education through mailings, and this group gets the education through a habit-based in-person group program. This is really important. Among the things that I want to say to you, and this is, again, I'm trying to talk to you not only about the ELM trial, but about methods in behavioral clinical trials. By the way, we call them behavioral clinical trials, but I actually like non-pharmacologic better because it's broader. We're talking about behavior, but we mean the same kinds of things that you mean in non-pharmacological. The problem is that it's hard to say, right? Non-pharmacologic, it's hard to say, it's got too many syllables. But anyway, it is what it is. We're sort of stuck with what we have. So we screened almost 15,000 people to get 2,796 who are potentially eligible. And we asked them a very important question, and it bears on the issue of who should our target population be. And we asked them, how do you prefer to manage metabolic syndrome? Because these people all look like they have metabolic syndrome. So 20% said, I don't want anything. I don't want drugs. I don't want you to come in with a lifestyle program. I don't want anything. I will have the metabolic syndrome and let the cards fall as they may. 40% said, I want to do drugs. I just want to do drugs. Don't mess with my lifestyle. I'm happy with drugs. And then another 40% said, I don't want to be on drugs. I want to try lifestyle. So the target population that we're coming to in this trial is not all people with a metabolic syndrome, but people with a metabolic syndrome who are really interested in making lifestyle changes. So how did we do that? How did we find the people who are committed to lifestyle? We did it in 2 ways. One is through information sessions, where we told them everything that we could think of about what it takes to be in a clinical trial, about what they would have to do if they were in each of the 2 arms, how they don't have a choice about which arm they get into, and it gives them an opportunity to consider their personal pros and cons of whether they want to be in it or not. In addition to that, if they got through the information session, by the way, this was required, then we had a run-in, and to be successful in the run-in, you had to wear an accelerometer, 10 hours a day, 7 consecutive days a week. If they stopped halfway through and broke up the consecutive days, they'd have to start all over again. And we did the same thing with monitoring food intake, and we also asked for a logistical plan for how they could access healthy foods and how they could engage in physical activity. And let me show you a couple of things. This is a slide from our, oh, you know, it's only got half of my slide here. I don't know where the other half went, but it used to be that over on this left side, there was a similar graph as this one, but it was a graph where only people who lost weight came back for the final evaluation. And what it says is that for those people who didn't come back, they're fooling us because we think our intervention is more successful than it actually is if you don't come back. See, sometimes people think about this from the point of view of a program. I'm going to do a program, and if I'm not happy with the program, I'll just stop doing it. And other times people realize what's involved in a clinical trial, which is it's not a program, and part of the obligation is to come back so we can evaluate things. And then the other side that is here is this is where everybody comes back. And you can see that instead of having the program be more positive than one would expect, the program works for some but not for everybody. So the interpretation is really quite different depending upon your return back. People don't want to come back if they haven't been successful at doing the things that we're asking them to do. So we're trying to tell them up front that this is the difference between a program and a clinical trial. Oh, here it is. So you see on this side, only the people that lost weight came back, and the people that did not lose weight tended not to come back, and we think, hey, the program was more successful than it was. Oh, that's interesting. Okay, another thing that we did, and perhaps this is the most important thing, in the early days when I was doing clinical trials, we did a hard sell on people. We said, hey, we've got this program, it is the best thing, you're going to love it, you should do it, you should absolutely do it. Okay, that's the hard sell. But what we wanted to do, and this is coming from the procedures of Michaela Kiernan, who developed this procedure, and essentially she calls it procedures associated with retention. And Michaela said, what we need to do is give people an opportunity to consider the pros and cons of participation. And so after we get through doing the best we can in terms of education, we give them an opportunity. The group has an opportunity on their own to fill in the matrix for the pros of being in the self-directed arm, or the cons and the pros of being in the group-based arm, and the cons as well. And so once they go through the information session, we let them go. And we say, if you're still interested, after a day or two, call us. We don't call them. So what we're trying to do is get a group of people who really understand what's involved in a trial, what's involved in changing lifestyle, and really want to participate. So the other thing that's important on a clinical trial methodologic issue is the preservation of equipoise. So we are not doing double-blind drug trials, where if you have a preference for a particular treatment, it really doesn't make much difference because both treatments look exactly the same. They're both pills. For us, in behavioral treatment, we have treatments that look very different. So if you come across and say, I hope you get into the group-based arm because that's the good arm, bad things happen. One thing that we're worried about is people would tend to get the preferred treatment on their own. And another thing that's equally as devastating to a trial is differential dropout. We have, people from people's point of view, if they have the bad treatment, they have more of a tendency to drop out than others. So preservation of equipoise was done in a variety of different ways. In the book that we wrote, we have a whole chapter on equipoise. We made everybody, investigators and staff, read the chapter, and then we had a series of webinars on equipoise. And in addition to that, we blinded, extended the blind. We did not do any interim reports. As a matter of fact, this presentation right now is the first time we've talked about any interim data from ELM because data collection has ended. And then from the investigator point of view, we're really emphasizing having passion for the question answering the question, but not passion for the answer. So equipoise is a key methodologic issue in non-pharmacologic treatments. So now let's get to the results. This is the consort diagram. We randomized 618 people. We had a screening to enrollment ratio of 24. We had to screen 24 people in order to get every person that was randomized. We recruited using electronic medical records and ads in social and mass media. And when all is said and done, we had only about 15% of the people who were missing at 6 months and also at 24 months. This is the baseline characteristics. So the age, the average age is 55. We had about 24% minority, 30% with less than a college education. About 85% of them were obese. The most common factor that they screened in on was waist. 98% screened in on having large waist, and the second most common factor was blood pressure. This is the main result at 6 months. We have a statistically significant difference between the two arms. This is the comparator arm, this is the treated arm. We get 29% in the treated arm and 21% in the comparator. Now, we were trying to get to 40%, so we didn't get to 40%, but we got close to 30%, which is comparable to 12 other trials that have been done on lifestyle and the metabolic syndrome. But all of those 12 trials have not looked at sustainability. It was what happens in remission of the metabolic syndrome while the treatment is ongoing. So that the 24-month result is something that's really terribly important. And then the other thing that I think is important about this is that we saw a benefit from our comparator. So keep in mind, the comparator group got a Fitbit, they got education, it was mailed to them, and we were expecting that the remission for the metabolic syndrome would be about 15%. So they're better than that. So possibly that could be due to the fact that we've got this highly motivated group of people who want to change their lifestyle. And in this kind of setting, less is more. We may need less intervention than what we would think otherwise, because these people are the 40% who are really interested in lifestyle change. So now I'm going to talk about the behavioral targets, and in doing so, this is the measure of automaticity, whether the habit is an automatic part of lifestyle. Think about that from the point of view, I do it without thinking about it. And then over on this side is the behavioral risk factor. Do they have a benefit on a standard measure of health behavior that has been closely linked to metabolic syndrome? So what we see in terms of vegetable intake is we have a benefit, small benefit, but a statistically significant benefit on the automaticity of eating vegetables at most meals, and a much bigger effect on the NCI vegetable screening. So people were eating, in the treatment group, people were eating more vegetables. And this one, this is our physical activity measure. So the question is, is taking a brisk walk an automatic part of your daily routine? By the way, this scale goes from 1 to 5, and the task is to get the score as close to 5 as we possibly can. 3.4 means that people are agreeing to a certain extent that it has become an automatic part of their daily life. And then over here, we measure the behavioral risk factor with an accelerometer. This is moderately vigorous physical activity minutes per week, and this is daily steps. And we see a benefit on both of these measures. This is probably going to be one of the most important outcomes that we have from ELM. In terms of sensory awareness, something bad happened here in that it looks like everybody, this is sensory awareness. Why is this important? Because we're trying to get people to pause and think about the smell of fat and the taste of salt and the colors and textures and smells of cooking vegetables and what it's like being outside walking in the changing environment, the environment that changes with the seasons. So something bad happened here, and everybody at baseline and also follow-up, regardless of whether they had any work done in the mindfulness, were improving on this measure. So that was sort of problematic. But over here, we're measuring sensory awareness using the 5-factor mindfulness scale and looking specifically at the observing facet. And what we see here is a big benefit in observing in the treated group relative to the control group. So in general, we're getting benefit on all of the targets of treatment. This one completely bombed. This one, so the idea here is the mindfulness practice is to pause before reacting. Why? Because people often eat without even thinking about it. It's just because it's there. It's opportunistic eating. Or people respond emotionally to unexpected interpersonal provocations. So we were trying to get people to just pause when something happens before deciding whether they're going to eat that food or whether they're going to respond to the person who's provoking them. And so we got no benefit on automaticity, and we got no benefit on the mindfulness non-reacting facet. And I will tell you personally, this is a hard thing to do. So we realized that we were having a difficult time with this, and we started talking to the interventionists about this, and the interventionists said, we don't know what to do. So we said, well, let's try it ourselves. So all the interventionists, we had 2 interventionists at each of 5 sites, plus the supervisors. Let's try it ourselves. And not one of us could do it. So it's a hard thing to accomplish, certainly needs more work than perhaps what we're doing in ELM. And then one would hope that we would have a benefit on the secondary outcomes, which we do. If the secondary outcome is in red, that means there is a statistically significant benefit in treatment relative to the comparator. So you can see we had a benefit on waist, body mass index, and weight. So people in the treated arm were losing weight and losing waist. We had a benefit on some of the cardiometabolic risk factors. But the 2 things that I want to point out here is this one. This is the quality of life, the SF-36 subscale on energy and vitality. And you can see that the score is higher in the treatment than the control. We were trying to get people to see that living a healthy lifestyle is not about deprivation, but it's about enjoying life because you have more energy and you have more vitality. And so we're seeing that in terms of the numbers. And then the other thing that I want to point out that we're watching carefully as we go through the 24-month outcome is this thing called co-interventions. So halfway through the follow-up, the GLP-1 obesity drugs came out, and we're thinking, oh, good God. People, particularly people in the comparator arm, are going to want to take these drugs as a way to augment what they're doing in the trial. So we evaluated every 3 months what co-interventions people were taking, because this could kill our trial. And so this co-intervention measure is drugs plus lifestyle programs that are now available all over the internet. And what we're seeing is more co-interventions in the comparator arm. It's not significant, but it's edging towards significant. So one of the things that we'll be looking at as we go forward is whether or not there are more co-interventions happening in the comparator than in the control group. And this is a forest plot. We have pre-specified subgroups, not much going on here, nothing is significant, but we do see a bit of a more benefit in the men than the women, and we see a bit more benefit in people who are overweight than who are obese. Okay, so this is the last thing I want to say before I close out, and this is our approach to implementation. So I'm going back to the NPI model. where there is a circle for intervention and then a subsequent circle for implementation. Greg, you should look at this. This is really important. Oh, okay, all right. What we've done, and what's getting increasingly popular in the United States, is to plan for implementation during the trial. So over the past 2.5 years, we've been interviewing stakeholders, because what we're trying to do is get a lifestyle program embedded into a healthcare system. So who are the stakeholders that are going to make that happen? You have to think about who I am. I'm a trialist. I'm a behavioral scientist who's a trialist. I don't have a clue about what's going on in the healthcare system. But I'll tell you, once you get into it, it is a very complex system with many people making decisions with diverse interests. And so we dove deeply into the healthcare system and interviewed insurers, healthcare financing people, potential business partners, implementation experts. We interviewed institutional leaders, physicians, and patients. And what we're asking them is, what would it take? If we find a positive benefit from this trial, what would it take for you to implement it in practice? So here's the most important thing we got from this. They said, we don't care about people developing, these are the insurers. So we're thinking the insurers are all going to worry about people having heart attacks or developing diabetes, which are high-cost elements. The insurers said, no, we don't care about that, because our clients change healthcare systems so frequently, we don't invest in our clients. But what we really are worried about is drug costs. Can you do something about cutting drug costs for the metabolic syndrome? So that was something that we then expanded in our assessment battery to make sure that we can speak to the third-party payers. And then the other thing that I thought was really interesting about this is the healthcare leaders. So what they said is, are you doing anything for patient satisfaction? Do patients actually like this? And we said, well, why is that important? If we show benefit on the cardiometabolic remission, isn't that really what you're worried about? They said, no. We're in a very competitive healthcare environment. We're competing with, in Chicago, we're competing with Northwestern, University of Chicago, any of a variety of different big healthcare systems. Patients are now much more attuned to what kind of benefits they get in different institutions. So if a patient satisfaction score goes up following your intervention, we want to know about that, because that gives us an edge in this competitive environment. So patient satisfaction is now in our outcome assessment battery. And then the other thing that I thought was interesting is that people kept asking us, first of all, this picture down here is the blind men and the elephant. The more people we talked to, the more we realized that everybody had a different set of interests, and it was really hard to figure out what to do. But planning for implementation is understanding what these interests are from all of the diverse stakeholders. And what they kept saying to us over and over and over again is, what about scalability? We're worried about scalability. You've got a treatment where you have to bring people into a small group, and they have to meet face to face. I don't know if this is tenable in our healthcare institution. And so what was happening as we're hearing this is COVID kicked in. And one of the silver linings around the cloud of COVID is that people have become much more comfortable doing remote care. So we said, okay, let's try a proof of concept for the ELM intervention that's fully remote. That's a virtual version. People don't have to come in. We do everything over the internet. And what we found is that the attendance shot up. We have never seen 95% attendance in any of the in-person groups. So the attendance shot up. Remission was about the same with the in-person group, and weight loss was about 50%. So what we're concluding here is that the world has changed, and COVID has opened the door for remote interventions, and that the ELM intervention, even though we're evaluating an in-person version, it's tenable if we do it fully remote. Okay, 3 more slides and I'm done. This is the first of the 3 slides. So I have been talking about methods, because one of the things that we're really big in the ELM trial, as well as the training programs that I'm involved in. So I'm involved in 2 training programs where we train young people on how to develop treatments and how to evaluate treatments using clinical trial methodology. So there are things that I've been saying, maybe not directly enough, but number 1, have a model for progressive treatment development. It doesn't make any difference which model you use, but have a model because it simplifies the questions that you ask at different levels of understanding your treatment. The ELM treatment has as its roots basic neuroscience, so the habit-based intervention is based heavily in basic neuroscience that says we got to get away from just initiating behavior into figuring out how to sustain it. The evaluation is guided by a hypothesized pathway because so many of our interventions fail because we couldn't get the participants to do the intervention. So we're trying to get beyond that by coming up with a hypothesized pathway and evaluating more systematically whether the intervention worked or not. The priority of protection of randomization, that's what equipoise is all about. So we want to make sure that people understand the bad consequences of being fairly confident that your treatment is going to work or preferring to have your treatment be beneficial over other treatments. So the consequences are what we are most worried about in clinical trials, and that is that the random assignment we had at baseline gets messed up during the course of the intervention. So now we have a situation where we no longer have comparability between the 2 groups, but we open the door to confounding, which means maybe one of the groups is different than the other group on factors that are unrelated to the treatment that is being offered. And that is the worst thing that can happen in a clinical trial. That is, you don't protect randomization and you come up with an alternative explanation for your trial, which is confounding, and the trial comes out to be a trial where the results are inconclusive. It's the kiss of death for a clinical trial. And then the next to the last slide is what we know about ELM. So we know we have a significant problem. We know this is the treatment of the metabolic syndrome with lifestyle is an unmet need. What we have at the interim is we have treatment. It was not as strong as what we had hoped to get because our original goal was 40%. We have a comparator that's stronger than we expected, 15%, but we still have a significant difference between these 2 arms. And the most important thing, we're positioned well for the ultimate question of whether or not this level of change can be sustained over time. Because as I said to you before, this level of change of 29–30% is what everybody achieves, but everybody achieves that with an ongoing treatment. And what we're trying to say is, we want to see if we can sustain that benefit after treatment ends. And this is my final slide. So this is the group that has done this multi-site trial. There are just under 100 investigators and staff who are involved in this. It's a huge trial. It's $10.7 million in funding. And this group was able to achieve recruitment goals in the middle of 2 pauses for COVID. That was extraordinary unto itself. And this group has also minimized missing data. Our goal was no more than 20%. We had around 15% missing data because of the quality of this group. So I am in great appreciation of being a part of a group that is so incredibly successful. And I thank you for your time.
Thank you very much, Lynda, to be here with us. I would like to share to the audience the chance to have Lynda with us. It's one of the greatest researchers in the US. Maybe 30 years ago in the US, it was impossible to manage these high-level, rigorous clinical trials assessing non-pharmacological intervention. It's just NPIs, it's very simple to say, because you have IBM, you can have IBM in the US, you can have also NPIs, very simple to pronounce, but it's a huge person here, a very famous person, because it's a real fight in the US, in France, in Slovakia, in Europe, to convince researchers, funders, to pay for this kind of study. It was impossible 30 years ago in US or everywhere in the world. So thank you to say to the young researcher from here, it's possible to design, to improve the quality and the rigor of the study, to share the results to all the population, not only the US population, but the world population. Thank you very much. Your book is absolutely fantastic, and of course, I recommend your book. Please, questions? Sure. Maybe this one?
This is a ripe phase 3 efficacy trial, and we have been working on this since 2005. It is a goal. Higher. Yes. It is a goal that you can achieve if you start small. And that is one of the values of having a treatment development model. You start small, which is what we did here, and you ask a series of questions. And in answering those questions, you progressively build up to something like this. So I don't want you to get discouraged. You can never do that. Yes, you can do that, but you have to start small and you have to work progressively.
Thanks very much. Questions? Iveta?
Thank you very much, Lynda. First of all, congratulations. It's amazing. And it's very interesting because actually we are planning a similar study. And I came up with exactly the same things that you have to tackle physical activity. I mean, in cardiovascular patients, physical activity, eating, and also mental health, all is very much important. And you saved me a lot of time because I just realized, or you just confirmed that with what we came at is exactly the same as you have here. But I have another question, or more a curiosity question, that when you motivate people to do small changes, like for example, brisk walk or physical activity, and I did not mention it, but I've heard a very fascinating presentation also at the European Public Health, at the European Health Psychology Conference in Cascais, that every step matters. That means that even if people just increase their physical activity by 15 minutes per week, not by day, per week, it decreases the mortality significantly. So my question is whether when you motivate people, let's say, to eat healthy or just to do a brisk physical activity, are they interested in doing more, for example? Let's for example, take salsa lessons or go to the gym or something like that. So as I said, it's just a curiosity question. Yeah. Is there a snowball effect?
What I didn't put up there is a 30-minute walk or equivalent. So some people are doing exactly what you're suggesting. Instead of doing a walk, they prefer to swim, or they prefer to cycle, or they prefer to go to the gym, and all of that is okay as long as they're working toward the goal of 150 minutes a week. And I think that the value of the habit is, if you think long term, how are we going to get people to do this on a regular basis? We have to simplify the habit and maximize the immediate reinforcers. So if people get into a mindset, oh God, you know, I have to go out and take a walk. They tell me that this is good for me. It's never going to be sustained. But on the other hand, if they think about, oh, this is the moment in time in my day when I can go out and smell the fresh air and see how my neighbor's roses are growing, or, you know, whatever. If we build on the immediate reinforcers of the particular habit, we have a better chance of getting sustainability. And I think we've missed that to a certain extent because we're health people, you know, and we're trying to improve health. But from the patient perspective, they want to feel good in the moment. And that, you know, that's what we're trying to get at. Yeah.
Thank you. Other question? Jenny?
Thank you, Madam, for this very interesting and enthusiastic speech and talk. But my idea is, shouldn't we...
Le micro.
Hold it up closer.
Yes, it's a very good speech, I say it. But shouldn't we complete the definition of metabolic syndrome by inducing the sleep apnea syndrome? This is a masked factors that's driven just during sleep and induce and favors hypertension, diabetes, but also sleepiness during the day and less motivation, and also polyphagia and induce obesity, and obesity induce sleep apnea syndrome. And this is a mask factor that we don't use to take into account, and maybe you can change it. What?
Is that a question? Are you asking a question?
Yes, it's a question. It's not a very question. I asked you to underline the importance of this factor that we do not take into account when we used to speak about that. And there is many non-pharmacological intervention to treat and to prevent sleep apnea syndrome also. So maybe in the NPIS we have to take into account also the sleep disturbances.
So are you asking a question about the target population?
Yes, also.
Who should we target? Because I think in the past we would target, so I'm working with the metabolic syndrome, and in the past we would target everybody who, as long as they have the metabolic syndrome, we would target them for our intervention. But I think what's happening is we're realizing one size does not fit all. And so we have to do a better job at aligning the treatment that we're offering with what the patient wants and could benefit from. And I think that is an evolution from this old thinking that we have, that everybody should be in our interventions except people for whom there would be a medical contraindication. So that's why we're moving forward and saying, but wait a minute, not everybody loves us. Not everybody wants our intervention. And we have to be, I think, humble enough to say, even though I think this is the best intervention in the world, not everybody would agree with me, and I'm going to find the people who really want that as a treatment option.
Yeah, it's a time for precision medicine, personalized medicine, but also public health, precision, and precision also for public health strategy, and not the all for everything, and very more precise. Please, another question here?
Yeah, just because sleep disturbances reduce motivation and enhance polyphagia, and so the problem is there.
Thank you very much for your presentation. I have a question for you with regard to the automatic habit versus habit with awareness. And in yoga, this is what we encourage, is people to be aware of what they're doing. So when you presented the result that it was not satisfactory in terms of the mindfulness, the pause before reacting, I was not very surprised because it's supposed to be trained. People need to be trained. It's like a training, right? So when you meditate, you learn to observe the thoughts, you learn to observe the reaction in your body, and to track the reaction, to track back the thought that preceded the reaction and even the urge to grab the food or etc. So, my question is for you: did you envision to train, people in those techniques of like mindfulness, meditating, observing the thoughts? Because I will suggest that it will improve the result on that level of the intervention, because it's a real training. It's not easy to achieve that moment then when you feel the trigger in you and you are able to stop, you are able to welcome and to hold space for the emotion. That is the cause of the act of grabbing food, of sitting there, drinking alcohol. You know what I mean? So yeah, that's a suggestion. Thank you.
A question of training.
Yeah, you have just described beautifully what we should have done with regard to that particular habit that we did not do. And I do think it's embedded into a more intense practice, and maybe the next step to try to have an impact on this is to bring in something like yoga, or something where it's a little bit more focused and intense than what we did. But you described it beautifully. Thank you.
Hello. I just have a question. Thank you for everything. I would like to have some more details on the other harm without intervention, because for me it's really a challenge to describe the people we will find in it. I know it's a randomization, but what do you do with these people? What do you offer in the study?
For the control group?
Control group, yes.
Great question.
What do we offer for people who don't have the opportunity to do the internet?
No, the control group
No, I mean, that's why we're doing, that's exactly why we're doing the multi-site clinical trial, because we want to increase the quality of the evidence that will open the door to implementation. So when you go and see your provider, I mean, the vision we have is when you go and see your provider and you say, I have the metabolic syndrome, I want to try lifestyle. The provider will say, hey, there's a program, there's an evidence-based program here at the clinic or at the medical center that can help you out. Right now, that doesn't exist. In the United States, medical practice operates on a system of referrals. If you go in and you go to your primary care doctor and you have shortness of breath, they refer you to a cardiologist. So that same thing should happen with behavioral programs or non-pharmacological programs or NPI. You're right, it's easier. It's easier. The provider should say, hey, there is an NPI program here that I'm going to refer you to, and you can use that program to help you optimize your lifestyle. It doesn't exist right now. But in order for that to exist, and being in a medical context, which we're in, the language of medicine is the phase 3 efficacy trial. If you look at some of the best drugs that we have, they were all tested in phase 3 efficacy trials. So what we want to do in lifestyle and behavioral and NPI type interventions is we want more phase 3 efficacy trials. We want to speak the language of medicine so that we can open the door toward implementation and practice. That's why we're doing it.
Yeah, that's why we were inspired by the work of Lynda and all her colleagues with the NPI model. We have recommendation for prototypic studies, for clinical studies, and especially to define what is a control group. And we respect all the rules international for public health research and health research. We have to do that. And also for implementation studies. In the NPI model, you can see the recommendation for implementation study. But it's not only one study, one moment, but a chain as drugs created 60 years ago, we have a chain of research and can produce some new NPIs. And it could be also a difference between NPI is the starter of maybe lifestyle change. It's not for all the life. The insurance, we not want to pay everybody for a long time. Yes, it's just a started moment. The NPI. It's very important. Please, another questions?
And we also have phase 4 pragmatic effectiveness trials. NPI model talks about it to go further. And the question is here.
I think that was a comment. Hi, thank you so much for coming. This is really, really interesting. It's been very, very great. Thank you. My question for you is just to know what your next research is going to be, and whether it's going to be continuation or whether you're looking at something completely different.
Yeah, I mean, we have to get at the 24-month result, and we are analyzing data on that right now. The data are promising that we have achieved sustainability, but the analyses are ongoing. So if it turns out that we weren't able to achieve sustainability, then we go back and we try to figure out ways to optimize the treatment. If it turns out that we are able to achieve sustainability, then the next step would be implementation in a healthcare setting. And so in the planning for implementation phase that I was describing at the very end of the presentation, we've talked to 2 healthcare institutions and said, conditional on the results, would you be interested in trying this out for a demonstration project at your institution? And we're getting very positive results, but they're all telling us, come back when you have your data, you know? So we're not quite there yet. But you know, following a model of treatment development, failure is a part of progress. So if it turns out that we don't get sustainability, then we turn around and go back, because ultimately we will be able to optimize and try again. And so one of the things that is difficult for young investigators is if they try to do a study and it doesn't work out, they think, okay, I'm going to walk away and go do something completely different. No, because failure is the seedbed for success. So if you fail, you know what doesn't work, and you can try something new. And that is the way these treatments get developed over time. And so if there's anything that we tell repeatedly to our young investigators is don't get discouraged because you're seeing a phase 3 efficacy trial. Start with small steps. And part of the orbit model, I don't know if you remember looking at it, but there are different phases and there are arrows that go both ways. So if you achieve support for the phase that you were in, the arrow says you go forward. But if in fact the study that you didn't pan out to get the results that you did, the arrow says go back. And what we're trying to do is normalize this concept that failure is the seedbed for success. So don't stop when you're faced with a failure.
It's really the perfect conclusion for this session. Thank you very much to be here. It's a great, great pleasure.